Good morning, everyone. Welcome to the 32nd annual meeting of the Society for Prevention Research. I'm thrilled to be here today. My name is Brittany Cooper, and I'm the current president of SPR. Welcome, everybody. We're so excited. This year's theme, thank you. Sure. This year's theme is advancing partnerships and collaborative approaches in prevention science. And SPR is always looking for new ways to do that, to create opportunities for the prevention community to connect and enhance collaborations. In fact, community and collaboration are two of our most important values as an organization. They're central to our vision, which is for SPR to be a diverse and inclusive community that leads the promotion of a healthy and equitable society through prevention science. So we're thrilled to be here together to do that together. There'll be many opportunities over the next several days to build and learn from this community. And I want to take just a moment to highlight a few ways you can do that at this year's conference. For the first time ever, we're welcoming over 100 prevention practitioners from across the country who are part of the Department of Defense's new integrated primary prevention workforce. Those of you who are here, you can tell because they have a nice little purple ribbon that says DoD Sparks. If you're here in the audience, would you mind raising your hand? I want to send out a special welcome to you all. Welcome to the SPR community. There are designated times and a location, the Columbia Foyer, for opportunities to connect with these folks. And I encourage you to do that. We're always looking for bridges, ways to build bridges between research and practice, and this is a wonderful way to do that. So welcome, and I hope you take advantage of that opportunity. Tomorrow's presidential plenary at 4:30 will feature a joint presentation from Dr. Nora Volkoff, Director of the National Institute on Drug Abuse, and Captain Chris Jones, Director of the Center for Substance Abuse Prevention in SAMHSA. They will be highlighting interagency partnerships and federal priorities in prevention that focus on community-engaged approaches. On Friday morning, I hope you'll join me at 10 a.m. If that's at the SPR business meeting, where it's an opportunity to learn more about what we're doing as an organization, what our goals are, what our strategic plan is, and how you can get more involved. So please join us for that as well. Following that, on Friday at 10:45, we'll conclude with our fourth plenary, which brings together speakers from across the other three plenaries to engage with one another, answer questions from the audience, and make connections about the key takeaways for enhancing collaborative approaches in prevention science. So as you can see, the major through line in all of this is connection, collaboration, and community. And so I want to also take this opportunity to thank the many individuals involved in the planning of the conference. Dr. Rhonda Boyd, are you here? Yes, stand up, please. Conference chair, organizer for this year's conference. Thank you so much. The SPR board, the conference committee, our NIH funders, and of course, Jennifer Lewis, the SPR executive director. Without their support, this conference would not be possible. So thank you all so much for making this what it is. Now, without further ado, I'd like to introduce our first plenary entitled Centering Indigenous Voices through Community Research Partnerships that Promote Health, Equity, and Advance Prevention Science. In the first presentation, Mr. Blane Garcia from Waianae Coast Comprehensive Center and Dr. May Okihiro from University of Hawaii at Manoa have been partners for over 20 years. They're going to be describing how this partnership has served an invaluable role within the community to co-develop, implement, and disseminate research to address community health disparities, especially those impacting their youth. In our second presentation, Ms. Crystal Austin, who is Associate Director of the Development for the Center for Indigenous Health, and Dr. Allison Barlow from Johns Hopkins Bloomberg School of Public Health, will delve into the Family Spirit Program, an evidence-based, culturally adaptable home visiting intervention designed for and by Native American families in partnership with Johns Hopkins Center for Indigenous Health. They'll be highlighting the program's co-design and co-adaptation methodologies and exploring how Indigenous community health workers are integral in delivering this intervention. So as you can see, we have a rock star panel up here to start us off for SPR's conference. And I'm really thrilled to learn more from both of their stories and their experiences. So I'll hand it on over for the first presentation.
Lana vale kuumaka, kau mai luna e. I ka ulu vehi vehi, o mauna ka ala e. Pi'i aku la i ki kuna o ka la, i na kuahiwi o Waianae. Ave ave ke alohi iho la i ka lama lama. O Waianae, ua pa'a ke kahua, o mauna ka lae. Aloha e, aloha kākou e, aloha e. Aloha and good morning, everyone. Just wanted to open up with a quick oli to acknowledge the space and the community that we come from, but also to acknowledge the lands and that we also are presenting on today. And we hope that we're able to share the community voices of the Waianae Coast and Waianae Nanakuli communities with you all.
Aloha mai kākou. My name is May Okihiro, and I'm happy to be here to present. I am a faculty member at the University of Hawaii at Manoa John A. Burns School of Medicine, but I'm most centered as a pediatrician and a community research at the Waianae Coast Comprehensive Health Center, where I've been for about 25 years. We call our presentation today Ho'olu Kaia'ulu, which means growing connections to preserve our community partnerships. And so our presentation today is more of what we call talk story about kind of where we are and how we've developed community research to support our community.
And my name is Blane Garcia. I also been working with May for a long time under the mentorship of her and the community work that we do. And my primary role is with the Waianae Coast Comprehensive Health Center, school-based health centers. It's a mouthful, where we have active clinics within the schools and then also with the research department at the Waianae Coast Comprehensive Health Center. So here's a quick snapshot of what island we currently reside in the state of Hawaii. So we're on the island of Oahu, and highlighted in the red there is the Waianae Coast. So that is the region that we currently serve in the state of Hawaii. And why this particular place? For one, this is the place where my piko is, which is the center and where my roots lay, and I'm a proud resident, born and raised in the community of Waianae. So it is who I am and what shapes me to be today. And I like to just acknowledge the historical sense and systems of care of how us as Indigenous people of the land and Native Hawaiians come about. And if you're familiar with the Ahupua'a system, this was a structure that was used in old systems and kind of what we're now kind of incorporating in this new era of the age. But it's really the concept of how the land takes care of us as we take care of the land, and it's very reciprocal. And everything in the land is very rich to us. And the saying is like, it's very vavai, meaning there's a lot of water, then we are rich in the land and so forth. So if the land is thriving, the people is thriving. Also, another important piece is to really acknowledge the historical cultural context of like where we are at in this generation. And we have to also acknowledge, like the Western contact of Captain Cook and the first colonization of introduction to disease. Oops. There we go. And then how the establishment of cash and economy came up in the state of Hawaii, which was really the enforcement of Westerners coming in and taking over the fisheries, the traditional fishing systems, and how they incorporated that into commercialization. And of course, importantly, the legal overthrow of our Hawaiian monarchy that happened. So these are all different contexts and things of how things built up and became a cultural historical trauma, if you put it that way, and the ban of Hawaiian language and so forth, and how Native Hawaiians were also eventually stripped from the lands when the sugar and plantations and everything came in, and then how that has affected what I mentioned earlier about like how we really relied on our land-based systems.
Sorry, I'm short. So it's not surprising then that Native Hawaiians, like many indigenous communities across the country and the world, experience poverty and many different social determinants of health. In the state of Hawaii, you can see here that Native Hawaiians have the highest prevalence of poverty. And if we look at those who are the working poor or ALICE community members, so it's acid limited, income constrained, but employed community members, Native Hawaiians, together with their prevalence of poverty, it's well over 50%. It's 60% of community members who are living day by day. Other new immigrant communities and from colonized countries like the Filipino community members also experience poverty and limited income. And then along with that, it's not unexpected then that we see high prevalence of persistent multi-generational health disparities. So on this slide, you can see here in the far right, these are statistics from our community, and that we community members suffer high prevalence of obesity, heart disease, diabetes. Many are tobacco users, and those are just some of our health disparities. The disparities start young. So Native Hawaiian and Pacific Island children actually across the country have high prevalence of obesity. In our clinic, over half the population by the age of 5 years are overweight and obese, and about 25% are severely obese, which is what triggered me into going into research. Native Hawaiian Pacific Islanders across the country experience high prevalence of depressed mood and other mental health conditions. Suicide was the leading cause of death in young Native Hawaiian adults 15 to 24 years of age in 2019. And in another survey from 2021 in Hawaii, more than half of the students in Hawaii never or rarely got the help they needed when experiencing sadness, emptiness, or hopelessness. And things definitely got worse during the pandemic, where we were seeing in our clinic kids who were gaining 60 to 90 pounds over a 2-year span of the pandemic. So things definitely got worse. So as a pediatrician, I've been seeing this over the last 20 years, and this is just an example of one of the kids that I might see in our clinic and have definitely seen. So this is an example, a 10-year-old boy, he's part Hawaiian, Chinese, Filipino, Portuguese, and a Caucasian. And he comes to clinic for a well-child visit, and we see that according to his body mass index or BMI chart, his first dot is well into the obese range. And so when I started clinical practice, we would do counseling, we would have them come back as all the best practice guidelines say to come back every month. And you know, it was not expected that suddenly they would, or they just wouldn't come back, or they would be very sad in clinic. And you know, I just knew that I was not doing a good job. And so I went back, I learned how to do clinical and community research. And I'll tell you, my experience that moved me into the community space was in my first presentation to our community IRB. I was approaching this building where the room where we were having our IRB meeting, and I was going to do I was doing an obesity prevalence study as my first study. And the community members, I could hear them, and they said, and one said, "Oh, she's doing another study on the O words." So we call them the O words, overweight and obesity. And then there was this chatter about why do they want to tell us what to eat? And I knew then that we needed to shift how we started looking at these conditions that the community knew all too well. And so one of the first studies that I did was looking at how our parents phrased the O words. So we looked at what the child's BMI was, and we asked the parents to answer the question, do you think your child's growth and body are, and then there was a range, just right, too big, or it had the small range, underweight, a little heavy, and overweight. And you can see here in the first graph, the dark blue bars showed that amongst the kids who were just on the, just getting to the obese range, that over 80%, almost 90% thought their child was just right. And on the lower graph, amongst the kids who are severely overweight or obese, still at a very young age, over 50% thought their kids were just right. And so that continues, although to a lesser extent as kids get older, but it really made us realize that we were not framing the conditions and the issues as the community saw them. And so we developed different kinds of tools like this BMI chart on the right, where we were talking about conditions in the context that people were worried about, the onset of diabetes at a young age, heart disease, that sort of thing. And we went through different trainings to teach people how to phrase things in a way that resonated with the community members. And then we really started focusing on upstream factors like the social determinants of health and looking at ways to change the social and physical environment so that the default choices are healthy ones, such as access to fresh drinking water. So we wrote some funding applications to try to get water bottle filling stations at schools and to try to make access to fresh water easier rather than just lecturing them about too much sugary beverages. And we really tried to do less emphasis on individual behavior change.
So here's a quick snapshot of the community. Uncle Gigi, who was a former founder of Waianae o Makaha, which is a community farms garden next to Makaha Elementary in our community. And kind of the way this came about is really the community and multiple organizations and nonprofits coming together and really forming this team and group called the Waianae Alliance, which is composed of various different, again, organizations in the community, and how they all came to the table and share that they're all dealing with the same things within their own groups and the populations and the families that they're serving. So this is kind of like how Place-Based Learning Alliance came about, and then the Waianae Alliance about, which continues to this day. But then also, why are we also here? We're also here is because I think we're lucky, and correct me if I'm wrong, May, is we are the only FQHC in the state that has a IRB established that is non-academic. And the way this kind of came about was really, again, the community and how, for example, Auntie Ipo, as you see in the picture there, and Auntie Shelley and Auntie Pua Burgess, not Pua Burgess, Auntie Paula Ann and Kaimi, they were approached by researchers in 1985 about a cancer study for breasts in women because they were noticing that on the Waianae Coast and Native Hawaiians, there's been a large disparity in cancer, and they were just approached. And again, we're targeted a lot for the health disparities that happens in Indigenous communities that I'm sure you folks are most aware of. And they wanted to work with the researchers to really establish things right by the community. And that's kind of how these key principles came up as guiding foundational work for the IRB and the CAG that I'm about to share with you guys shortly, is really working with the researchers to be understanding of, and they have to know that they have to acknowledge this process as they continue to work in the community if they are approved by the two governing boards. Is being sensitive to the culture and the study of the participants, always provide direct and immediate benefits to the study participants and the community as a whole. What does this look like? What do these results mean to us? How is it benefiting us as a community? Is our community understanding the metrics that are being measured? Because if you think all of that stuff is not being measured, if the community doesn't understand the questions that's being assessed to them, are we really doing justice by the Indigenous people in the community of really assessing, or as researchers, are we just being selective and getting the data that we want without any benefits to the community and the people? And then also empowering the community leaders of the community, because they are the key stakeholders within the community that really helps them become the driving force of the research study. So it's really giving the ownership to the community to really drive the research project at its fullest. and that in a nutshell. And accompanying that IRB board is we have a community advisory group that's formed, and this is a bunch of kupuna and community members. And I'm actually lucky enough, I'm the youngest on the board. And we really complement the IRB aspect because IRB is really good at going through like all the academic language and then really helping it to simplify. So by the time it comes to the community advisory group, we're able to give them the feedback truly as a community member of like going through their surveys, like, do we really understand what these questions are asking, as I shared before, and really helping them shape the images of how they're advertising the projects in the school. And the way this comes about is the PIs of the research projects come and they set up a separate meeting where they present their work to us. And then we have a very long discussion of talk story and really working through all of the things. And then gives us a sense of who they are and their intentions and how we can really work together better to really help improve the identified health needs within the community.
So we're really proud of our research infrastructure at the health center, and to emphasize that our job is really to ensure the protections and relevance of studies to our health center mission and to our community, that all research coming through our health center must acknowledge and support our cultural and community practices, beliefs, and values, and show that they are being respected. We had a study that came through that wanted to look at maternal mega obesity was the term. You can imagine how that did not go over. Researchers must, in their application, describe community and individual benefits. They must, in some way, strengthen our research infrastructure capacity. And so that's often funding, training, and those kinds of things. There must be collaborative arrangements for planning and implementation. So it's not that the researcher can come to our health center, set up a table, and start advertising. There's got to be ways that they're working with our staff and empowering our staff. There needs to be budget equity. So community and health center time and expertise are fairly compensated. And I really push for 50-50. So there might be even if it's a small study, they've got to somehow figure that out, that there's some compensation. We talk about data management and data ownership a lot. All the data is still owned by the health center, and that we have some say in what happens with the data. And then the community and health center staff somehow participate in the data analysis and in the dissemination so that we know what happened with each study. And so the research that comes through our IRB, and I should say I'm the director of the research department, and Blane has been a really active member along with Aaron Ramirez here, who's also part of our research team in ensuring these practices.
So this brings us to another example that addresses the high suicide rates that have been happening in the community prior to the pandemic, and then also as that has exacerbated after the pandemic. And if you guys are familiar, by show of hands, how many of you are familiar with the Sources of Strength program? Woohoo! So the way this came about is it was, again, a very, very high need demand from the community. And we have another mentor who is a part of our team, Dr. Deb Gabert from the Department of Psychiatry at the John A. Burns School of Medicine, who does a lot of advocacy around suicide prevention in the state. And she had partners, and long story short, we became the first community in the whole state of Hawaii to implement Sources of Strength program, which is a very upstream process that focuses on strengths-based approaches and building peer-to-peer leaders versus focusing on the traumas that has already kind of happened. So it's a very strong public health upstream approach. The beauty of this program that I like is very adapted around the medicine wheel, which in our culture are very similar to the Lokahi wheel, which each component has some kind of aspect of learning about how you balance yourself and how does that maintain your health. And then how do you identify with those strengths and those pieces that kind of may be on this day or this week or this month a little bit depleted, and how do we regenerate that with our peers in our community. And that's all been adapted into the community and how that has shown the relevance. But the beauty about it was really allowing the youth to really take over the program and adapting it in the community and really creating it to be molded into what fits the community and the culture aspect of it. And it was conducted in 2 different communities. And although we're on the same coast, the Waianae community and the Nanakuli community, they're very different from each other. And there's a bit of rivalry. If you've gone to school there and graduated from there, there's a bit of rivalry between that. I'm sure very similar in other communities. But Nanakuli was the first community that implemented the source restraint program. And then a few months later, Waianae community started it at the high schools. And another long story short, to this day, it's still being implemented and being asked for. And it's actually expanded to other DOE complexes in the school. And Dan and his team has come down a lot to the state and done a lot of trainings. And then we're also allowed to train more trainers as we're trainers to train trainers. There's another term for that, I'm sure that they use, but basically the goal is really just spreading hope, help, and healing in the community in any aspect. And I think that's why I love this program so much, because it's very interactive. It doesn't rely on any kind of presentation. It's very youth driven, and the youth are really able to create it for what itself in their own school and do a lot of different advocacies that just doesn't focus on mental health. It focuses on a whole broad range of other things.
So Sources of Strength really emphasizes that research isn't just research, it's bringing new ways and methods and strategies into the community. And Sources of Strength has been a really powerful way to show that of introducing new concepts and strategies and then sustaining them after the funding is all gone. Sources of Strength funding went away about 3 years, no, before that, 4 years ago. So as the pandemic was winding up, I should say, we had the opportunity to apply for some NIH funding, the RADx Up funding to address COVID testing. And at that point, in the beginning of the pandemic, Native Hawaiian and Pacific Islanders, as well as Filipinos across the country, were experiencing incredibly high rates of infection. And so the goal of our application, and this was a University of Hawaii application, was to increase testing capacity in Native Hawaiian, Pacific Islander, and Filipino communities across Hawaii. And our aim was really to strengthen our community academic partnerships to address the COVID-19 pandemic, to build already on the successful strategies that were happening at health centers and in their communities across the islands, not to come up with our own in White Tower types of testing strategies, but to use what was on the ground and strengthen them. So for example, our health center had the only COVID hotline in the state. And so we worked on strengthening that. We had an incredibly successful and busy drive-through testing where people were coming from across the island to come to our testing site. And we really want to focus also on building a public health infrastructure. And so we successfully, through that partnership, received a couple of different NIH grants. And then really worked with the health center staff at Waianae and 4 other health centers to build on the infrastructure and the testing capacity. We also expanded our research infrastructure. At that point, there were just a couple of us working in the research department. And so we brought in community members. Aaron was one of them. Aaron was working for the airline industry, and that collapsed during the beginning of the pandemic. Airline employee could definitely be used on the ground. He became a community health worker and really a star in our research department. And so we brought in more staff from the community and we trained them on research basics, human subjects training, but also in the service delivery. So we all went through contact tracing, infection control training, the basics of managing COVID and when to reach for help, and what were the community resources that were in play at that point. And we had a big team addressing all these issues. And to do that, we needed budget equity. And so all our grants, again, were 50-50 because the community knew what to do. And we were the academic arm was just helping to measure what was happening out there. And then project governance was really important, that our community members who are part of our research team were equal members in all the decision-making of what to do next. And so just an example of what we did as the pandemic was evolving, the schools began to request more testing at their sites. They weren't getting the support that they needed. And so by their request, we started a school testing program, initially at the largest conversion charter school in the state, which was in our community. We first started, and they really called out what we should be doing. We started with the staff and the teachers, and then that grew to the students and other community members. And the level of testing at the different schools as we expanded depended on what the schools needed and wanted versus what we were demanding as researchers. And so we tweak things according to the needs. All the results were shared, and we began doing these weekly infographics so that the community could see what was happening, because, you know, as data people, we were always looking at the statistics. And so we would make these infographics, and, you know, the team would create these infographics every week, and then they'd be disseminated out to the community. And so our team, I have to say that our team was well received, and we were like part of the team, like, where's PAC? We called ourselves PAC, for Pacific Alliance Against COVID-19. And it was also like, where's the PAC team? Because we became part of the whole COVID infrastructure there. We trained students and staff and really strengthened our partnerships with the Department of Education and Department of Health. And I think this was the bottom line, that we built trust with community about research and about clinical care. So teaming with the community, we had consistency. We always said that if we were going to show up, we could not cancel, that we had to go to the site, even if we ended up only testing 1 or 2 people, because we had to be consistent. We were transparent. We were approachable, and again, equitable decisions made by the community members for the community members. And these are just some photos from our team and some of our school testing. And this picture on the corner here is the principal at our charter school, who was just a star. So as the pandemic was then winding up in the fall of 2022, we had another opportunity to apply for funding. And this is the NIH Compass program, which I think is going to be presented later on in this conference, or Community Partnerships to Advance Science for Society. And so this call for proposals really focus on community and had to come from a community organization. And we come from a community organization, so we were kind of right in the correct position for this application. And so we had been already working with community partners, especially the Waianae Alliance that Blane mentioned, which is this incredible group of what we call Aina-based Native Hawaiian organizations supporting Native Hawaiian practices and values. And that the Compass program called for structural interventions to address health disparities, or efforts that change environments and processes that shape and constrain behaviors. And so, you know, in that program, there were 25 funded projects, and we were lucky enough to get one. So I just want to briefly touch on that.
And with our culture comes naming, right? It's very important to us and how the name really connects to these projects. And, you know, we're very in tune with our elements, and I just want to share like what we call Ho'ailona. And Ho'ailona are like elemental signs that happen around us, and that's kind of like how names come up with community discussions and key people in the community and how we put together names. And this came about is Kama'ehu o ke Kaiaulu, which means thriving youth of the community, if you do a little translation. But what it really means to us is that kama ehu, if you break it down, kama means children or child. Ehu is that beam of light when that sun peaks the horizon, when the sun rises, and then it just gives you that warmth and that uplifting spirit of it's hard to explain. It's something you just experience. So that's what that ehu part of that what children in our community give to us and the community ultimately, and how they're the next generation, why they're so important. And Kaiulu is community in Hawaiian, Olelo Hawaii. But also we're lucky is that it's also the name of the wind that blows to the Waianae coast, which is also named Kaiulu. So it's very fitting of how things came together. Another important one is this is Uncle Eric, who is one of the founders of the Ka'ala Farms up at Ka'ala, which was connected to the Oli of Mount Ka'ala, which is the highest peak on the island of Oahu, which is one of our biggest protectors on the Waianae coast. And a famous Olola Ono Eao from our kupuna is Ikava Ma Mua, Kava Ma Hope, which means really the lessons learned from the past are the key to the future, meaning that we learn from what's happened in the past and we always remain perseverance, and we as a community, and how do we incorporate those lessons learned and how do we strive forward and move forward with together as a community. And so we always have to look at the standard of care, right, and how the Western medical model of care also aligns with the traditional model of care and how the community aligns that, and then how that's connected to what we believe is lokahi, the overall balance of our health, which is related to our overall health and how that relates to the medical system and our health center. And we see that, you know, with everything that's happening with the mental health crisis that's happening with the youth and stuff, it's like we're really seeing that something more is happening in the community that can't only be addressed within the clinical setting, that more can also be done in the community. And how can we collaboratively bridge that together to be equal, and then also expanding the way of reaching more families in the community, and how do we expand that? Because we know something just isn't working, and we're trying to figure that out because we have other modalities in the community and other organizations that what they're doing is making a difference in the community. And how do we now bridge that together to work cohesively together that complements whatever the family seeks for themselves as the healing modality or the healing method for themselves, and how do we support them on that journey and that path for themselves as a family?
So in clinic, we definitely screen our kids when they come in. We take their weight and their height and get their BMI. We do depression screens and anxiety screens according to the Western best practices. And along with those best practices, we refer to psychologists if we find signs of depression or anxiety, school failure. And if their BMI is, you know, in the obese range, then refer to a dietitian. But for years, we have known, and this is especially true post-pandemic, that most of the kids did not want to go see a psychologist. Their parents didn't want them referred to a psychologist. There were long wait times. If they did go to one appointment, they often dropped out. And so we knew that we have known for a long time that system was in place. We were improving that system, but it was failing a lot of the kids. In terms of what I call chronic disease risk, which often starts with obesity and poor nutrition. Again, we were referring them to our dietitians, but as wonderful as our dietitians and psychologists were, again, most of the time, families did not want to go. And so as we were talking to the Alliance members and talking amongst ourselves and really reflecting on what it is that the community wants and what are the community values, we knew that it had to include community. And what if instead of this Western best practice, what if we could refer to community and that community could refer back to us? What if instead of just a psychologist or a dietitian, we could refer them to one of our farms that were growing some of our incredible traditional foods? What if we could send them to another Aina-based organization that was working on environmental conservation and working in the forest to try to rejuvenate our lands? What if we could send them to another incredible community organization, Eala, who's working on traditional voyaging and building a traditional canoe? What if we taught those community organizations about basics in mental health, about the community resources, including all the incredible resources we have at the health center, so that we weren't siloed anymore, but we were actually working together. And so that's the basis of our Compass project. Our health center, again, is the lead, and our research partners, so again, there's been a shift, right, in how this research project goes. Our research partner is the University of Hawaii. We have at the center, the Ahaku Kamaehu, which is our community council. And this AHA is council. AHA is also the braided senate of coconut, but it's bringing together these community members, most of who were have been part of the alliance, to help lead this project, not advise, but lead this project. We're also putting together a youth assembly that Blane and a couple of others are charged with to bring this youth group together, and then forming our bringing in additional members for our HERA, or our Health Equity Research Assembly, who can in the long run, after in the 10-year program, make sure that this structural intervention is sustainable. Our community council, or AHAKU, is looking at outcomes of value, not in the medical model, but in the community model. And so we're putting together the community framework. And for example, not just looking at the biologic and behavioral determinants of health, but the important cultural determinants of health and outcomes, which is so important to community members.
So as May was mentioning, I really have the privilege of working with the youth in the community and the next generation. And I think the reason why I think I'm lucky to really connect with them is because I kind of love they're kind of the shoes that I used to have before, because of the same schools that they attended, which is also the same schools that I attended. And as much as they tell me that I empower them, I think they don't realize is that they're more so empowering me and what they bring to the table in the community, and how bright our future looks for our community and our people with this next generation. But it's really continuing to train the next generation, and really, I think a collective dream of ours, and I know we're probably running on time, is that we would really love to have a pipeline of some sort. And that's just a term of really having direct ways of empowering the youth and really having them an opportunity to go and seek whatever they want to do, whether it's in farming, construction, public health, medicine, nursing, you name it, that we're able to advise them and mentor them through that process during high school, even since during intermediate and post high school and college, and navigating that. And even if they don't go to college, how we still be able to maintain that peer-to-peer mentorship with them, so that way they can really come back and be the next healers of the community. Because what better way is that you get to see your own people in the setting that are the ones that are helping your families in the next. And these are just the various different examples of internships that we've had that youth been a part of. But the one I'm going to be speaking on more is the one that we just had this past summer, which is Ho'olu Namamo. And the youth came up with this name as Ho'olu means to grow, to sprout, like seed sprouting. And Namamo is, again, the growth of the children. So it's like the growth of the next generation. And this is all named by the youth. And the way this came about is, if you guys are familiar with the lehua, Ohio lehua plant, the lehua is a yellow blossom. I don't know if you guys are following the news. It's also like something that's happening on the Big Island with rapid Ohio death, which is a very indigenous, important native plant to our ecosystems because of how it sustains the watersheds in the forest and all that stuff with the cycles. So that's kind of how the youth came about that. So there's at Kamaila Academy, we have a youth advisory council that really is governed by the youth. And we're literally, I feel like we're just flies on a wall, and we're just there to be the instruments of how we can better assist them in the process of whatever they want to advocate for. And to our surprise, this past school year, the youth really wanted to focus on rebuilding the bathroom infrastructure at their school. And as adults, you wouldn't think that they value the bathrooms as important, but I think we found it very important that they valued it, and how they've come up with a little needs assessment, and we kind of just help them, build those skills and really doing that. And within the next week and so, when we return back home, they're actually going to present that back to their admin team, which is the principal that you saw getting swabbed who you see there pounding kalo with some of the youth there. So they're excited to present their findings back to the school admin. And the focus of that was really to not just identify the problems, but they knew that if we identify the problems, they also have to come up with creative solutions, because if they don't come up with the creative solutions themselves, then we're just stuck at that problem thing. And we don't want it to rebound where it becomes a blaming factor, right? That's not how community works. We work together to find solutions and establish solutions. And this past summer, oh my gosh, it was so sad that the summer ended because the youth are no longer with us every single day. And they were just so empowering, but this is just really a program that focused on helping the youth really understand who they are and their culture. And not all of them are of Native Hawaiian ancestry, but it was really a beauty to see everybody, all the kids from different parts of the community, and come together. And there's even 2 youth who weren't born in Hawaii. They're actually, they have affiliations with families, but they just weren't born here. So it was an opportunity for them to really learn about their Hawaii Noa, their Hawaiian name, and what that meant. So we really work with them to learn about who they are as a person, their name and what it means to them and why they were named that, and connecting it to cultural practices. So you see them like learning how to dance hula. They learn how to chant the oli that I did in the beginning as well to introduce us and the place that we come from. So that in a nutshell. And
So we'd like to mahalo and thank all of you and the Society for Prevention Research for inviting us here to speak. Dr. Scott Okamoto from Hawaii Pacific University and the University of Hawaii Cancer Center for really connecting us to the society, and then our funders. So thank you very much.
Morning, everyone. It's such a blessing to be here, and thank you so much to our colleagues for such an amazing presentation. And I just want to say a special acknowledgement of SPR to start us off with work in Indigenous communities. From my 33 years working with Indigenous communities, I've come to understand that they really hold the original instructions of prevention science and public health. And I think that's because of the value system that knows that there is collective responsibility for all living things and that all living things are connected. And that's really the basis, I think, of public health and of prevention. So thank you to SPR for really centering this work at the beginning of our conference. And my name's Allison Barlow. I'm so honored to be presenting with my colleague, Allison. I'm at Johns Hopkins Center for Indigenous Health.
Nani shtejit bahan shlo do kia ani eya bashichin. Twitch eatni dashachego on hozoni eya dashanella. And Crystal Austin eya dashajin. So I gave an introduction in my Navajo language. Yad is the word for it is well in my language. And we're so happy and proud to just be here as on these lands of the Anacostans and Piscataway and Pamunkey peoples. And, you know, it's very, when I introduce myself in my language, it is also I pay homage to my family. From my mom, who is Bitterwater, to my father, who is from the Towering House people, to my maternal grandfather, who is Bitterwater, and to my paternal grandfather, who is the Yucca Strung Out people. In Navajo, Hashkan is the word, Hashkan Hotzohni is translated to Yucca Strung Out, but Hashkan is the word that means banana in my language, and it's this banana fruit that grows on the yucca. And for a long time, I kept thinking that, you know, banana splits has something to do with my lineage. So it's really funny that I am here. I think I presented on family spirit for a very, very, so many years ago here at this conference. My adopted community often probably thinks of me as Grandma Spirit. So I've worked on family spirit for a very long time, and it is something that actually began sort of by accident. You know, my oldest child just graduated high school a few days ago. And when she was a little over a year old, I started my career at the center. And I thought that I was going into a job that would be very easy, that would be easier than teaching a bunch of early childhood, you know, aged kids, like 3 to 5-year-old. And I thought I was taking sort of a vacation because I was becoming a mom. And I applied for a home visiting position, and lo and behold, it was one of the most challenging jobs that I have ever loved doing. Over the years, my position there has changed, but I always remember, you know, going into these homes and being with family in a way that just really compelled me to follow this career path ever since. So I'm not really a researcher, but I am a community member. You know, I'm a mom, I'm a grandmother, I'm an aunt, I'm a sister, I'm a daughter. And I'm also, you know, someone's grandchild. And so that's sort of the space and the voice that I'm coming from. And so I'll tell you a little bit about the center and who we are, a little bit about what we do, and then I'll tell you guys the story about family spirit. So Johns Hopkins Center for Indigenous Health was formerly known as the Johns Hopkins for American Indian Health. And in the last few years, we've made a change to Indigenous health. And this felt much more appropriate for all of the communities in which we are working. And so we were founded in 1991 at the Johns Hopkins Bloomberg School of Public Health in the Department of International Health. We worked in partnership with communities to advance Indigenous well-being and health leadership to the highest level. And our vision, very much like our colleagues that just presented, is thriving Indigenous communities worldwide. Our center's scope and our footprint is much in the US. You know, today we have over 300 staff members working with our center. And this has been a huge explosion in the last few years. And it is just really, really just heartwarming to know that many of my colleagues are actually in this room. And many of my colleagues are also at the front lines in our offices out in the Southwest and the Great Lakes area. We work over across 28 states throughout the country. So this is just a little bit of information about Indigenous peoples today, and just to share that this does not include Native Hawaiians or Pacific Islanders, although we would, you know, although they are indigenous to these lands. So we have about 3.7 million natives that live in the US. There are also over 2 million that live in rural reservations. I come from the Navajo Nation, and so this is near, the Navajo Nation is in Arizona, Utah, and New Mexico, and I come from sort of the central agency near a small community called Chinle. Most of the reservations are west of the Mississippi, and while there are this many millions of natives that are still here, there's also many native languages that are still spoken. And there is such a rich geographic and cultural diversity amongst each of these tribal nations. But at the center, there's also many shared values that we all hold together. So this may not be new information for many of you, but this is the truth that actually is, that is existing in my communities. So Indigenous people in the U.S. face staggering health inequities resulting from generations of trauma. So there are numbers here that just can be very staggering, but this is something that many of our community members, many of my relatives, you know, still contend with to this very day. Poverty, unemployment, food security, water insecurity, and just, you know, the challenges with education. All of these things are issues that many of our people still face to this very day. And so when we think about these issues, many times we often think about, what do we do? You know, our grandmothers, our grandfathers, and our leaders, and many community people, members have often thought about what is, you know, how do we help? What do we do? You know, how do we make changes? And so this is where family spirit has, you know, come into play, and you know, family spirit is an Indigenous-based early childhood home visiting intervention. I've worked on family spirit for most of my career, and so I'll tell you a little bit about this as we move along. So family spirit began over 25 years ago. Started with a seed, you know, and this began to grow over the last years, and we will tell you, so 25 years ago, our center was doing a lot of work around infectious disease prevention. So we're doing a lot of immunization work, and as our community members were going into homes and, you know, talking with families and their young children, there was a huge recognition that there needed to be a different type of intervention, one that actually supports families and gives them information on, and to empower them to be the best parents that they could be. And so we started a project, you know, threw together some education, because that felt like that was the biggest need at that time. And so, and this was really focusing on nutrition and breastfeeding support. And so the SOS project began. But as many, many things, this grew as emerging needs began to appear, and it changed numerous times. And so since that time, we have done several randomized control trials, and we're actually starting some additional programming. But the story began here in the Southwest with the White Mountain Apache, my own tribe, the Navajo Nation, and our cousins, San Carlos Apache. And this is just a picture of our family spirit research team. Some of them are probably going to be upset that I'm showing this right now, because they still work with us. So the intervention components for family spirit, you know, family spirit has become the, you know, the largest and only evidence-based and culturally tailored home visiting program designed for Native families. This intervention is delivered by Native paraprofessionals as a core strategy to support families from pregnancy to 3 years postpartum. Parents gain knowledge and skills to achieve optimum development for their children across the domains of physical, cognitive, social, emotional, language learning, and self-help. And these 63 lessons are taught from pregnancy to the child's 3rd birthday. This is such an important way of thinking about support. When you have families coming in, someone coming in to visit with you, spend time with you, to be your advocate, to be your champion, to take time to talk with you about all of the things that you might be dealing with, as well as that person lifting up the strengths that they see with you. This is what home visiting and what home visitors do. And so it has just been a real amazing experience to be able to see the power of this. And so families, we recognize that in many of our communities, families do not live by themselves. They live with numerous other family members. And so family involvement is a huge component. We also are connecting our families to the services that they need, whether it's housing, whether it's traditional medicine, traditional Navajo or, other tribal traditional practitioners. And so then that's over 3 years of providing one-on-one support. So this has been, this was designed through a very important process that took over 10 years to do. Here you see pictures of the White Mountain Apache members. So what do the communities want to change? Well, we have to ask, what do they want to do? And their number one priority was helping young families to thrive. So this thought of having our children grow up to be healthy in mind, body, and spirit. And so that was what came to the top of these conversations that we held as part of our interview, stakeholder interviews with moms and dads. We've had numerous conversations around the table. We've worked with community advisory board members in each of the communities that Family Spirit was at. And so some of the challenges that were identified for young parents, again, may not be new information, but a lot of the history from which we come from are some of the losses that were stripped of, that we were stripped of, the identities, the languages, the practices that we come with were something that people were trying to hang on to. And in some cases, these were removed. And so that was a huge influence for families to deal with. And also 39% of Native females were served by the Indian Health Services began childbearing in adolescence. And then also the same group had high rates of drug use and suicide and other behavioral challenges. And another barrier to healthcare, another barrier was healthcare and parenting education. And so if you can imagine, all of that is always like in this cycle of that just continues. And so where do we begin? And we began thinking about this cycle when there is unprepared parenthood that can lead to other subsequent actions, right? Like early childhood neglect, poor school readiness, behavioral problems, early substance use, dropout, worsening substance abuse, and then cycle repeats itself. And so when we've thought about where to begin, it only seemed natural and parallel to a lot of Indigenous beliefs that we had to go work upstream. We had to think about those critical times of supporting families before the child is even born. And so that is in my culture as a Dene woman, we often think about those times of preparing the family to receive this human being into their life way before the child is born. Binsikes, their thought process, yalti, their language, and all of the things that they have to do that to prepare for this baby would be something that just worked very much aligned. It aligned with what this intervention was. And that is what our community members said. And so we had to begin with really looking at some of the strong cultural assets and opportunities that were identified through the CBPR. Tribal cultures support and strengthen family-based approaches to prevention. There's so much, even though there's been challenges within our communities and our cultures and our ways of doing, our ways of living, there is still a lot of strengths, you know, and so that was something that we had to tap into when we think about this intervention. We also recognize that teen parenting was not stigmatized, right? And so a lot of times the childbearing age began very early in our culture, in our communities. And then we also had to consider the tribal leaders and stakeholders that supported this model. And we had many of that. Our leaders, our community leaders, our tribal leaders, our stakeholders were in it with us. And we also recognized that our communities really wanted us to serve our own. We know what would be best. And if we're able to have our communities become the teachers, become this trusted ally in the growth of these families, that was very important for us. Home was also the choice as the intervention setting. This was also a very unique approach. You know, we had community health representatives for a very long time in many of our communities. You know, they would come to the homes and they would see the elders and, you know, do these really, you know, brief checks on them. But that idea also was, you know, seemed to be a very natural way for us to also deliver this type of service. This helped to reduce stigma of being seen at the clinic or a particular building. And there's a lot of people that in our families come with a lot of pride as well, you know, and they want to feel safe in anything that they walk into. And so by being able to bring services to them, it really helped to alleviate even the challenges with having to get anywhere. So the transportation was a big issue. We also were mindful that home, where their fireplace is, where their food is at, where their water is at, this is also that source of strength for them. And there's so many other resources and teachers and supporters that we could also, you know, team up with to be able to support this family. We also wanted to invite them. And sometimes our home visitors would become facilitators in being able to invite grandma and grandpa or aunt, you know, uncles to be able to sit in on these conversations and impart to them stories and life lessons. So another part of the CBPR process was just deciding who do we work with. And young parents and their children from this young age was something that we were felt like a very appropriate age for us to work with, because they were you know, part of these multiple generations. We also had a huge opportunity to make an intergenerational impact. And so this was also very important. The choice of who gets to do this work. Back in those days, 25 years ago, the experts, the people that does this work was probably, according to many people, that the nurses were the only ones that could do this work. but we knew that where we lived, that was a challenge. You come to Chinle, the movie theater is an hour away. You come to Chinle, the mall is 2 hours away. You know, there is so many conveniences that just don't exist in our rural communities. And therefore, to get people that were from, you know, that were trained as nurses to come and stay is very challenging. You know, that challenge still exists to this day. People are there for a short time before they move on to the next place that they do work. And so shortage of nurses in these reservation settings was not possible, and we could not depend on that. But our community members also felt, you know what, we need to be able to train our own community members. Culturally, these are the aunties. The aunties are the moms also. You know, we are the second moms to our sisters' kids, you know? And culturally, when we greet our children, we greet each of these children as our own. So why not? It's only made sense. And so we trained up paraprofessional home visitors because they were able to navigate the cultural, contextual, social mores required to do these home visits effectively. And by doing that, we were able to also promote local workforce development. There is nothing much more empowering in raising health leadership than by investing time and resources and support to community members, local community members. And so we found that that was the secret sauce, right? Indigenous family health educators. There's something very special about these group of people that come into homes. You know, each week they show up and they listen, they hear, they're patient, and they're really a special group of people. But they, throughout the time that they are with these families, they experienced or developed a lot of trust. Trust is a huge issue. You know, when you go in as a patient into a hospital setting, there's often someone across the desk from you or across the room from you who does not understand your way of thinking, who does not understand the things that you have to contend with to get your healthcare needs met. But this person did. And they're also the compassion, a compassionate way of being, a compassionate way of delivering services, a compassionate way of listening to all of these things that families have to share. And by being who they are, I think they didn't realize they were also role modeling different ways of a different way of being. And so they are the true community change agents. So over these years, and through the process, we were able to identify and create several different lesson content. We have now 63 lessons. And when you think about, you know, people say, oh, there is no parenting book on, you know, available, you know, and I say, yes, there is. It's called Family Spirit. And so far it's worked. You know, I had a kid who graduated, so I think I just have to provide the one lesson about finances, and then we should be golden. So we've done things around goal setting. We've talked about well childcare. We talked about some of the harder subjects around family planning or substance abuse prevention, depression prevention and referral. So we talk about some of these things that you don't have time for in the doctor's office. And then we want to also tackle a lot of these other things that impede our lives. So the lesson, these lessons are really help to it was important for us to create a culturally grounded content and format. So we used a lot of familiar stories. You know, some of the home visitors, if they're out on Navajo, they might be talking about scenarios about Pasch's, which is the, you know, the local grocery chain as they're sharing these scenarios. There was also a lot of our illustrations, or all of our illustrations, was done by a Native artist. And our home visitors also have had seized these opportunities to provide cultural activities and provide additional resources. So when we're talking about pregnancy, we might be able, the home visitor might share a story about what that means for Navajo people. What are the stories there? What are the lessons there? Our lessons are designed like this. There's a page that the participant sees. Often it's very visual. There's a little teaching point, or, you know, things that we can read together. But on the other side is a ton of information that really helps shape the health educator. So very much like this health educator utilizes the information there to, you know, to focus on and provide support to these families. So this last one is just looking at this theoretical model. And so this was adapted from Patterson's model, but we have, when you think about where a family comes from and all of the things that this family has to contend with in order to raise their child and have this child grow up, you know, there's a lot to consider. And so for family spirit, we felt like through home visiting, there's 3 areas that we really should focus on, because this is the place that we can really be effective in creating change. That was the parental factors, the stressors that influences the parenting. And so we focused on, you know, ensuring that parents were getting really great information to help empower them as they make decisions, as they, you know, determine all of these next steps for raising their children. We gave information that really helped families to develop new coping skills for problem solving or substance use, and connected them to the places that can really help them and support them. And that's what we did with this, because we were really trying to make this huge impact on the parental factors and stressors, because that is such a direct link to parenting. So family spirit is designed to strengthen parenting, plus help to deal with behavioral and mental health issues that can impede positive parenting. So all of this was really important. And it's been a really great program for me to be a part of. So I'm gonna hand time over now to Allison to talk about how well it worked.
Thank you so much. I'm gonna go really fast because I think we have about 10 minutes. Is that right? Okay, great. So I'm just gonna hit some highlights. I'm gonna switch through some slides. I just want to say one thing to start, and that is I want to think a little bit about Dr. Okamoto, and we both talked a lot about culturally grounded work. There's been criticism in the field that culturally grounded work is really hard to prove effective, from that Western standard of academia. And this is a great refutation that that's not true. And also there's been a sense of it's not scalable because it's been made so perfectly and carefully in communities, it's not scalable. So this is intended to throw all of those ideas out. So I'll just show you a little bit here. So the last trial that we did was supported by NIDA. And if Dr. Aria Crump is here, I just want to say thank you to her. She's been our program officer. Woo! Yeah, she had confidence in this program that, you know, it was developed as a culturally grounded program, but we put in an application to see if, can we show that it actually reduces risk for substance use? And so NIDA supported this. It was a randomized controlled trial, but the thing that the community really drove to ensure that those in the control group or comparison group got a very beneficial service. So they got transportation to all their prenatal and well baby visits and connections to resources in their community. These are just baseline characteristics from the teen moms who participated. So they're about 322 mother-child dyads. They were young. The average age of the moms was 18. About 3/4 of them, this was their first child. Only about 40% were in school. One of the really important things, there was a lot of housing instability. So they were moving a lot, which poses a lot of challenges to home visiting. So keep that in mind because there's a great success story in this. They also, about a third had elevated depression scores, and over 84% had lifetime drug use, alcohol, marijuana, meth. So a lot of challenges within these young people. But these are the impacts that we found. So if you remember that theoretical model, we were working in 3 domains. And so the parents experienced increased maternal knowledge, self-efficacy, reduced parent stress. The moms had decreased depression, substance use, and fewer overall risky behaviors. And then where the rubber meets the road, the kids had these beautiful outcomes. They had better social, emotional, and behavioral development and lower clinical risks at age 3 for lifetime behavioral mental health issues. And we used a measure called the ITSE to look at externalizing, internalizing, and dysregulation, which are really these early building blocks or predictors of lifetime behavioral and mental well-being. So this is just the scores for the children, and what we just love to see is that the brown line that goes across were the national norms among children who did not live in poverty, did not live in communities who experienced historical trauma. And these children at the end of this, their rates of externalizing, internalizing, and dysregulation were really coming down toward those national norms. So amazing effects. The really exciting thing is we just got funding again from NIDA. We're following up with these children. They're now 18 to 20 years old. The moms are 33 to 39. So we're going back to learn, was this sustained? What happens over time? So these outcomes were sort of packaged and promoted. And what happened after that is we got national endorsements from this program from HomeV. And I just really want to reflect on that middle point. So remember that housing instability where families are moving like 2 times a year or more. But this had the highest participant retention of any home visiting program that had been reviewed. So 22 programs. And the reason is the secret sauce. Those home visitors, they were relentless. They knew where to find anybody in their community. So it's just such a cool, I think, outcome. This program, through this evidence, has now scaled to 167 tribal communities across 28 states. Non-Native communities are now using it. Why? Why do they want to use this? Because they really love that paraprofessionals are teaching it. They love that it's focused on 2 generations of behavioral and mental health. And they say, like, when they read the curriculum, it really reflects mindful parenting. And that's the Indigenous piece of it. So that's really exciting. The curriculum's now been digitized, so we can make really instantaneous upgrades. So during COVID, putting out lessons on COVID, tax benefit information, and so forth. And the greatest thing that happened a year or 2 ago was we competed for an international prize. And we were awarded by the Lego Foundation a major grant to take family spirit to Indigenous communities around the world. So we're now working with Aboriginal communities in Australia, Aotearoa, the Maori peoples, and First Nations Health Authority in Canada. So we're just so honored to do this work, and we're going to learn so much. They're putting so much more into this that again, the continuous quality improvement through these partnerships. And then just briefly, so we have a colleague whose name is Lisa Martin. She's Indigenous, she's amazing. And we started to think about, like, most research looks at the average effects of an intervention. And we know that some people benefit more and some people benefit less. And there are all kinds of reasons why that is. But how can we meet families where they are? How can we tailor curriculum to exactly what they need? Nobody needs 63 lessons. There's going to be all kinds of lessons that people can skip, but there are also going to be things that they need more of that there's only 1 or 2 lessons about. So we're doing lots of work now to build new modules. So we've built new modules specific to nutrition in early childhood, to post-COVID, really acute mental health risks for moms, addiction, overdose, suicide, and then there's huge language delays among kids because of COVID. So we have a Navajo speech pathologist, Joshua Allison Burbank, who's developing this languages medicine modules, and we're all of that work has undergone new trials and is rolling out. So I'm going to skip through that whole bit, and we're going to end with a quick video. Community knows best, but this is just the story of this work through the eyes of a participant and our rock star Crystal.
A kinship with everyone here. Everywhere you go, anywhere in the world, you run into another Navajo person and you say, yeah, dang, I'm from here. This is my clan. And then automatic, it's like, you're my brother, you're my sister, or you're my grandma, which makes you sort of, in a sense, responsible for one another. Family Spirit was developed by our center in the mid-90s. It's a home visiting intervention program, a family strengthening program. We have been able to recruit families at 28 weeks gestation or earlier and teach them using a curriculum until that child turns 3. There are some families that have a lot of challenges, poverty being probably at the top of all of this. Some may face limits within their education, maybe single parents. Some may have been actively involved with drugs and alcohol. One of the first families that I recruited was a young lady by the name of Charmaine.
And you've seen me struggle as a single parent.
She lived in a place that had no access to electricity and running water, reliable transportation.
Back then, I was still learning how to embrace my motherhood. I feel like now it has been so long ago. It was fun, but now you gotta stay dry. We don't want you to get sick. I'm comfortable being a mom. I love being a mom. I love my kids and I love my home. You remember when you were a little boy? Crystal used to come over here into this house when the floor was still dirt.
When your baby is first born and you're holding them, shake their hands and say to them, Yate shawe. Halane.
Back then, I was ashamed of where I came from as a Native American. We're like, we're at the bottom of the list. And now to be able to stand up and say, I am a Native American and I love being American. That's where I come from. That's my land. Probably go to school for, like you said, early education, childhood education. I'm able to say this is Crystal P from Family Spirit. She helped me, mommy, when I wasn't very strong. She came in and spoke to me and helped me to, raise you guys right and raise myself right and to grow myself right and to view an outlook on life in a positive way. My husband and I, we're planning on building a home. We're going to get a horse, so we're going to have a horse corral. It's going to impact their children. This is what mommy taught us. And, this is how you're going to, grow up. And it's going to go on to their grandkids and the next generation of kids.
Charmaine is such a lovely, lovely human being. She just graduated with her early childhood degree last week. Yeah. I just want to just say that when we did this video of Charmaine and asked her to share her experiences of being in the program, she used words that were, she said, I was angry. I was, I was so angry and I was upset with my life and up to that point. And, but over the time we kept showing up and I kept showing up and I kept showing up. She just changed so much. And I love that her house had learning posters and the solar system hanging from the lights, So those were the changes. And these are the stories that each of us are striving for. And for me to be able to share with you that Charmaine graduated, she's an amazing community organizer, a community leader. I mean, that just blows my mind. And it's not just because of just us, but there was so many other people who were invested in her success. And so thank you all.
What a powerful way to start the day. Thank you so much. Please give another round of applause and gratitude to these two teams. If you want to learn more, we're going to host a roundtable in this room with these speakers to talk more about this topic. So please come join us at 10:15 in this room, but also go and enjoy the rest of the conference. Thank you so much.